The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome to the next episode of TMD Demystified. I'm Tony Urbanic. And today we're going to talk about the philosophy of treating TMD. That's the title of today's episode, the philosophy of treating TMD. We're going to get right into it because I need to hold this definition of philosophy on my iPhone so that I can read it for you. First, we're going to define philosophy, because what you probably already hear, you go along and you go to a dental meeting and they bring up the topic of TMJ, and somebody wants to talk about TMJ, or the speaker talks about TMJ, and the next thing that comes up is, well, what's your philosophy about treating TMJ? Or what's his philosophy about treating TMJ? Or my philosophy about treating TMJ is blah, 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 blah. Or I heard his philosophy is da, 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 da. Everybody seems to have a philosophy about treating TMJ. Actually, TMJ is what you'll hear. They don't, philosophy of treating TMJ, which is obviously the name of the joint. So if you would communicate or argue with me, first define your terms. You first must define your terms. So let's define philosophy for us, and then we'll get into what I have to say about this, because it's important. The establishment, the dental industry, the dental profession, has not stayed on point about treating what we now call TMD. So let's get on point by starting, first of all, discussing this concept of philosophy about treating TMD. So philosophy, noun, there are four definitions here. It can be, number one, the study of the fundamental nature of knowledge, reality, existence, especially when considered as an academic discipline, natural philosophy. That's what kind of philosophy you'll learn in college if you take a philosophy course or two. I actually had enough philosophy in my college experience I could have majored in philosophy. Number two, a particular system of philosophical thought. So, example, Schopenhauer's philosophy. Number three, the study of the theoretical basis of a particular branch of knowledge or experience, the philosophy of science. So you can have kind of a more scientific concept to philosophy. And then fourth, where when you're talking about the philosophy of TMD, all of this concept drops into the fourth definition here, which is a theory or attitude held by a person or organization that acts as a guiding principle for behavior. Let me repeat that again, because that's the philosophy, the kind of philosophy, the definition of philosophy I'm going to be talking about. Because you hear it all the time. This is what you hear when you hear about, oh, my philosophy about treating TMD is blah, 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 blah. A theory or attitude held by a person or organization that acts as a guiding principle for behavior. Like there's a philosophy among the oral and maxillofacial surgeons who has a subset of the American Association of Oral Maxillofacial Surgery who focus particularly on the temporomandibular joint surgery, and they have a particular philosophy, which we'll touch on a little later on, their philosophy about treating TMD surgically. So let's talk about these little philosophies that have sprouted up over the past, well, since 1936. So we're talking about 90 years now, roughly. 85, 90 years since the inception of the concept of temporomandibular joint disease with Dr. Costin syndrome, 1936. And then it fell into the lap of dentistry to try to solve this problem of symptoms associated with the temporomandibular joint. So the first philosophy that I want to speak on is the treating temporomandibular joint symptoms with the occlusion philosophy. There are a lot of proponents of this, big names, I think certainly very well trained, very adequate doctors whose mainly, almost exclusively, their entire philosophy about treating temporomandibular joint problems, along with other kinds of symptoms, but especially temporomandibular joint problems, is by reconstructing the occlusion. And the philosophy there is that if the teeth fit together correctly, then it must make the rest of the maxillofacial structure cooperate in harmony, I guess would be the best word that's used by these gentlemen, by these doctors. And these would be doctors like Dr. Spear, Dr. Dawson, the Pankey Institute, and even LVI. And they have a philosophy about reconstructing the occlusion, and it is respected out there, highly respected, highly thought of by some, highly trained through their philosophy. But does by reconstructing the occlusion decrease inflammation within the temporomandibular joint? Because we've learned, I found out, I will stick to it and show you how, and this is all established in other episodes by certainly better than I'm going to do it right now, but how inflammation within these joints will create all of the symptoms, the headache, the earache, the shoulder pain, the ringing, fullness, dizziness, et cetera, directly. If you decrease inflammation, the symptoms will decrease. They're related one-on-one, if you decrease inflammation. All right, so reconstructing the occlusion and giving, a perfect or semi-perfect centric occlusion, or even a centric occlusion that is exactly the same as centric relation, and having them ideally exactly the same. That's a good thing. There's nothing wrong with it. But when you do that, does that necessarily decrease inflammation within the temporomandibular joint? Well, I can think of a couple reasons why it wouldn't. If the damage is already there to a prior acute trauma, or there's chronic inflammation there due to chronic bruxism or clenching or grinding, and you can have a perfect occlusion and you're still going to have problems because the chronic inflammation is there in the temporomandibular joint and isn't decreased. So treating the occlusion is a philosophy about trying to treat temporomandibular joint problems, but doesn't address the real problem, which is inflammation in the joint. The next one that I've spoken on often is the philosophy of treating the muscles, and that is multifaceted. Treating the muscles, whether it be physical therapy on the muscles, chiropractic on the muscles, massage on the muscles, Botox on the muscles, botulinum toxin A, on the muscles. You can paralyze the muscles. You can massage the muscles. Muscles can cause pain, no doubt about it. If you work out too long in the gym too much, and it can cause pain. But where the pain originates is where the muscles get tight, squeezed down, whether it be facial muscles, neck muscles, shoulder muscles, arm muscles. When they contract over the normal amount, they will pull over a normal amount on the periosteum where they are attached or where they are inserted, the insertion or the attachment, and they stimulate the nociceptors, and that's what causes pain. So if a particular muscle hurts, you can use the philosophy of treating that muscles with different modalities. Another one comes to mind is TENS. The TENS unit, tend to relax muscles. Yes, TENS will relax the muscle, or medical injection into the muscle, but it only treats that particular muscle and doesn't treat any of the other symptoms that are associated with inflammation within the temporomandibular joint. So that philosophy of treating muscles and monitoring muscles with the myomonitors to say, well, that muscle is tight, that muscle is overactive. Yes, it is. A myomonitor is really good at detecting and producing on a meter of one kind or another the contractile force or the motion of a muscle, but it doesn't address the problem. But that philosophy is there, and we hear it all the time in dentistry. So that's a philosophy of treating TMD, is treating the muscles, the philosophical muscles. Yeah, the myofascial pain dysfunction syndrome, which originated by Dr. Laskin in 1969, wrote a nice article about it, but really in that article or anything else that followed that really did not identify really what the causative agent is of all the symptoms, inflammation. And treating the muscles is best as a short-term solution at a very localized level, short-term solution at a very localized level. But that is one of the philosophies of treating TMD. The next one that comes up is the philosophy of treating D by treating the patient's emotions. So it's a philosophy of, well, a patient clenches, grinds, has bruxism. We can fix that by decreasing the bruxism because their emotional problems are out of whack. And if we get their emotional problems straightened out, then they won't clench or grind anymore. Well, that has partial truth to it because we see it all the time. I see it constantly. I had one patient yesterday that immediately came to my mind, a very, very, very emotional 20-year-old young woman. Actually put her in a device and her symptoms went away rapidly within the first 6 weeks. She literally said yesterday that all of her TMD symptoms on that list, headache, earache, jaw pain, neck pain, shoulder pain, which were her major symptoms, they were gone. And I said, well, what percentage of them, how would you average that all out? And she said 75%. I said, well, what's the 25% that's still there? She didn't hesitate. She says, my entire lower face feels numb. And I don't want to get too deep into it, but even her mother was aware, and I did not have to say it. Her mother brought out, having an anxiety attack as an explanation why all of the symptoms on the TMD list went away, but she was complaining of a numb face. I mean, she said the entire face was numb. And mother knew her child well enough, and I didn't have to say it. I kind of started to talk about it, and before I got too deep into the explanation, mom just blurted out, I think you had an anxiety attack. So we know, admittedly, that anxiety causes bruxism. That's the only thing we do know about it. Anxiety causes bruxism. Stress causes anxiety. Anxiety causes bruxism. We don't know how. We don't know the mechanism. We know it's in there, probably in the brainstem, almost for sure, where this all goes on. But there's the philosophy used by psychiatrists and psychologists about treating the emotions in the hopes that it's going to treat TMD. Well, treating your emotions may at times decrease your bruxism until you have the next stressful event, the next event in your life. And even patients are well aware of it. I hear it all the time. Patients will come in, they were doing well. They come in with 80, 90% of their symptoms are gone, and they'll come back after a year and they'll go, I'm having symptoms again. And then before I say anything, before I even look at the device and see what's going on, they say, yeah, I've really been stressed. Yeah, I had a death in the family, or I'm going through a divorce and I'm really stressed. They acknowledge it. They know there is a relationship. They know there's a relationship to their bruxism. In the cases that I just described, it's pretty simple. You make sure the device is still separating the posterior teeth enough and that fits well and they're comfortable with it in your mouth, and then say, put it in your mouth more often. Go back to wearing it another 8 hours a day plus nighttime. Or a lot of them, they quit wearing it at night. They come in, they're having more symptoms again, and say, have you been wearing a device? Oh no, I quit wearing the device a year ago. It's like, well, no, put the thing in every night. You got to wear it every night. That's part of the protocol. So the psychiatrists and psychologists, attempt to treat the emotions to decrease stress, and everybody has it. And it'd be nice if you could have no stress in your life. Wouldn't that be great? But stress causes anxiety. Anxiety causes bruxism. And sometimes it's worse. Sometimes it's not as bad. But treating the emotions is not going to decrease inflammation within these joints. But that's a philosophy of treating TMD, or combination of all three of these. The next philosophy is treating the nervous system by drugs, and that's a philosophy held most often and seen most visually by the physicians, who pretty much, unless you're a surgeon, your philosophy is, well, if you have a problem, we'll find the right drug for that. So you have the philosophy of treating the nervous system with various kinds of drugs, muscle relaxants, neuroleptics, pain medications, opioids. I had a patient that I commented on the last episode, major part of the last episode. Middle-aged woman ended up on opioids, and addicted to opioids, placed on there by a physician, because of the philosophy of, well, treating these pains with drugs. And in the long term, none of them are effective, and all of them, to a greater or lesser degree, have tremendous side effects that you don't want. Opioids being a really good example. She was placed on fentanyl. So you have the philosophy of treating TMD with medication, drugs. And actually there is a set of drugs that work really well on inflammation, and they're the non-steroidals. And they really do work very well for a short period of time. And as you should know, or I'm sure most of you know, the non-steroidals have a very short life on actually decreasing inflammation, whether it be in the joint or in your elbow or wherever that inflammation is. You take enough of it, it is not effective anymore. Generally, you get about 2 weeks out of effectiveness of taking non-steroidals. And then all they do is tear up your stomach. They hurt your stomach. You keep on taking them, you're going to complain of stomach pain, because they're going to cause gastritis. And your stomach will hurt. And your stomach will hurt more than whatever was hurting before. So, they're not effective over the long term on decreasing inflammation. And certainly opioids are not, and muscle relaxants are not, and soporifics are not, and neuroleptics are not. They don't decrease inflammation, but they're used constantly by doctors who have this philosophy of treating TMD. And then, of course, I won't beat around the bush. There's the surgical philosophy, and I dealt with that in my career for 36 years. The philosophy that treating the temporomandibular joint surgically is going to fix the problem. And it does in some cases, we have found out, and the cases that it is effective on, you take enough of the joint out that is inflamed, then if it's not inflamed anymore, the inflammation will go down. So a simple meniscectomy actually has been, by the numbers, statistically shown to be somewhat effective, as has been a device that I used quite a bit called the Christensen device, was somewhat pretty effective using and decreasing inflammation, but nowhere near the amount that it should have been. In my own experience, this is my experience, roughly 50% of the patients, if I did a meniscectomy or I did a Christensen implant and meniscectomy, they would be back within a certain amount of time. Roughly 50% would be back within 6 months to 2 years with the same symptoms, which means that surgery was not successful. And that's why I quit doing surgery 12 years ago. But there's a surgical philosophy. But I finally got to the point, well, this philosophy is not good enough for me. It's not good enough for my patients. I mean, even patients who have total joint replacement and use, both replacement of the glenoid fossa and the condylar head on what we call in surgically total joint replacement, not all of those are 100% effective. And those particular surgeries open up the patient to significant amount of unintended consequences and complications, potential complications with those surgeries. But that's one of the other philosophies, the surgical philosophy of temporomandibular joint. And then the final philosophy that I've heard from the beginning of my career in dentistry, and that is the philosophy of doing nothing, not treating. Now, sometimes actually the philosophy of not treating something is a good philosophy, but the philosophy that it applies here is something that I have heard frequently, and that is, if you let these patients suffer long enough, if you let them have pain long enough, the inflammation, or literally, without defining the word inflammation, the problem will burn out. They call it joint burnout. And what that boils down to anatomically, physiologically, is that enough of the temporomandibular joint deteriorates and the patients get old enough where it doesn't hurt anymore. And there are cases of that. Now, why that happens, but when that happens, I can promise you that when you inspect that patient and you inspect the x-rays on that patient, what you're going to find is a significantly degenerated joint to the point where the condyle is significantly misshapen, part of it not there, the old hockey stick, the way that, you lose enough of the joint. The condyle is supposed to be shaped as a ball. And as you start losing bone structure, it starts from the inside out, actually, in most of the cases. That's called subchondral cyst. And you get blank areas, open areas within the condyle, and the surface starts to break down. And then you end up with basically a hockey stick with bone missing here and the condylar surface missing here. And then you start getting occlusal changes because the mandible drops back. Not less than ideal, caused by the philosophy of doing nothing. It's like, but that's a philosophy. And then some doctors, they combine these philosophies. They go, well, my philosophy, I prefer to go to the philosophy of doing some drugs and treating the muscles. And then if that's not good enough, then we'll just let it burn out. And so that's like a complex philosophy of the philosophies to treat the temporomandibular joint. These philosophies are held in differentiation from actually the science. Because what I discovered, and I just hate the word discover because all of this information has been in the literature. I pointed it out where you can find it and how it developed. But, inflammation within these joints act just like inflammation in the lateral epicondyle and tennis elbow. And tennis elbow and how tennis elbow creates muscle tightness and pain and symptoms of the forearm and the wrist is the same problem that TMD is with inflammation in this joint. And tennis elbow and this relationship has been known by the orthopedic surgeons for more than 60 years. So anything that I talk about, I discuss, I teach, has been in the literature. Some of it more known than others. And dental students all know that 90% of the loads on the temporomandibular joint come from the posterior teeth. That's why posterior teeth are multi-rooted. That's why posterior teeth are much larger than anterior teeth. That's why you can put tremendous loads between posterior teeth that you cannot put between anterior teeth. 90% of the loads on the temporomandibular joint are from posterior teeth, but it's all about whether or not there's inflammation within the joint. If there's inflammation within the joint, that is the definition of TMD. Inflammation in the joint equals TMD. That's simple as that. If you can get the inflammation to go away by unloading the joint long enough, like a set of crutches would unload a bad knee, then that will allow the inflammation to decrease, which allows the symptoms to decrease. Just like a set of crutches would allow the symptoms on a bad knee, inflamed knee, damaged knee, to decrease if you stayed on crutches long enough. It's that simple. So what we know, what I teach, how you decrease the inflammation on the temporomandibular joint using a disoccluding posterior disoccluding device, which we had to call the Urbanic device and protocol, actually is extremely scientific and not a philosophy about treating TMD. It actually addresses the mechanics and the cell biology and the mechanisms, physiologic mechanisms, neurologic mechanisms that create the symptoms directly from inflammation within the joint. So there's a big difference between treating the TMD successfully by decreasing inflammation, which is very scientific, not a philosophy, because it can be traced right back to the science that has already been in the literature. I didn't create this science. I just discovered that it was there and connected the dots that were already present. So next time you hear you're at a meeting or you're talking over lunch with one of your colleagues and complaining that you had a patient with TMD and you really wished that they would just leave your office and asking about, well, what's your philosophy about treating TMD? You might consider saying, well, I don't have a philosophy about treating TMD. I actually treat it very scientifically by decreasing the inflammation within the temporomandibular joint. And to give it the plug, using the Urbanic device and protocol. If you, as a listener, as a viewer, would like to join our growing group of network providers, doctors who use our device and protocol successfully, like we do here, and the other network providers use consistently for the same results, predictable, high degree of success, using the device and protocol, you can contact us easily. I am reachable at Tony at urbanictmj.com. My Director of Marketing and Education, Naomi Williams. Dr. Naomi Williams is available at naomi@urbanictmj.com. I encourage comments, criticisms. I'm welcome to look forward to talking to any of the Spear Dawson or Pankey advocates. I don't need to argue anything, but I'd like to explain, and you can explain to me why the occlusion, adjusting the occlusion or remaking the occlusion, reconstructing an occlusion is going to decrease inflammation in these joints enough to make the symptoms go away. I'll be happy to discuss it with you on a professional colleague basis. But I honestly can't get anyone to criticize or make any kind of disparaging comments, even unknown, from unknown sources. After over 100 episodes, not getting any criticism about what I teach, what I say, what I've found, what I recommend. But I like to communicate. I like to teach. And of course, you can see and learn quite a bit on our website, which is www.urbanictmj.com. Until next time, I do look forward to the next episode. I put off a couple topics just to get this one in. I thought it was timely to talk about why there should not be a philosophy of treating TMD, but only a scientific, effective treatment, not a philosophy. With that said, I look forward to the next time when I can speak with you. I'm Tony Urbaniak, and this is TMD Demystified.